Hey everyone, welcome to The Explainer. I'm so incredibly thrilled you're here today because we are going to master one of the most fascinating topics in modern medicine, intravenous anesthesia. If you're staring down a daunting, long-form exam question on this exact subject and feeling a little overwhelmed, seriously take a deep breath. You are in the exact right place. By the end of this explainer, you are going to have a perfectly structured, comprehensive blueprint to write an absolutely stellar, top-tier essay answer. We're going to build your knowledge up step by step, so let's just jump right in.
To make sure your essay is totally bulletproof, everything we're covering today is sourced directly from the Ultimate Clinical Blueprint, Rang and Dale's Pharmacology, 9th edition. Grounding your essay in high-quality, peer-reviewed pharmacology literature like this, yeah, that is exactly what examiners are looking for.
All right, here is our roadmap for today. 1. The magic of induction. 2. How IV anesthetics work. 3. The star player, propofol. 4. Thiopental and etomidate. And 5. Risks and unwanted effects.
Section 1. The magic of induction.
Okay, let's dive into this. To truly appreciate intravenous anesthesia, you kind of have to picture the horrifying reality of surgery before 1846. As our source notes, before these agents existed, surgeons literally relied on operating on struggling, fully conscious patients at lightning speed. Basically brutal, rapid amputations against the clock. When you start your essay highlighting this stark historical contrast, immediately shows the examiner you understand the profound clinical revolution these drugs represent. We desperately needed a way to put patients under, completely and safely in the blink of an eye.
And that brings us to our core definition. You want to write this down exactly. Intravenous anesthetic agents are drugs used for the induction of anesthesia that produce unconsciousness in about 20 seconds. Literally 20 seconds. They act the very moment the drug travels from the injection site straight through the bloodstream and reaches the brain. And they're preferred over older gas masks because, let's be honest, a simple injection completely lacks the menacing, panic-inducing quality of having a face mask clamped over you when you're already apprehensive.
Section 2. How IV anesthetics work.
Now, if you want maximum points on your long answer, you need to state exactly what anesthesia means physiologically. It's not just going to sleep. It involves 3 specific, distinct neurophysiological changes. First, unconsciousness. Second, a total loss of response to painful stimulation. And third, the loss of reflexes, and that means both motor and autonomic reflexes. Deliver these 3 points super clearly in your exam, and you've instantly proven you understand the fundamental goals of the anesthetist.
So the crucial question is, how do the cells actually make this happen? Well, here is your step-by-step cellular flowchart. Step 1. The highly lipid-soluble drug reaches the brain rapidly. Step 2. It works primarily by enhancing GABA-mediated inhibitory transmission. Now, think of GABA as the brain's main off switch, and these drugs essentially tape that switch in the downward position. Finally, step 3, they simultaneously inhibit the release of excitatory transmitters and block postsynaptic receptors. Basically, you're slamming on the brain's brakes and entirely cutting the accelerator.
And where exactly are these brakes being applied? While these agents do affect the whole nervous system, they have main targets you should definitely list out: the cortex, the thalamus, the hippocampus, the midbrain reticular formation, and the spinal cord. Listing these specific anatomical targets adds a really fantastic layer of precision to your explanation.
Section 3. The star player, propofol.
Introduced back in 1983, propofol is incredibly potent and amazingly rapid. It's an excellent little trivia point, but clinically relevant, that it's colloquially known as the milk of amnesia, due to its milky white appearance. But don't let the nickname fool you. As a strong mnemonic anchor to help you remember its sheer potency and the danger if it's misused, our source notes that the singer Michael Jackson tragically died from a propofol overdose. It is a very powerful, serious drug.
And this brilliantly illustrates the ongoing evolution of pharmacology. See, propofol originally had a problem. It has very low water solubility. So it had to be formulated as an oil and water emulsion. But that formulation hurts like crazy upon injection, and the emulsion unfortunately supports microbial growth. Yike. To solve this, scientists developed fospropofol. This is a water-soluble derivative that's much less painful on injection, and once it's inside the body, alkaline phosphatases rapidly convert it right back into active propofol. Mentioning fospropofol in your essay, that shows a deep, modern understanding of drug formulation.
Pharmacokinetically speaking, propofol is basically a dream. It has a rapid onset of about 30 seconds and a very fast rate of redistribution, with a half-life of just 2 to 4 minutes. But more importantly, its metabolism follows first-order kinetics into inactive conjugates. This means the body clears it efficiently and, most importantly, predictably.
Because of this rapid recovery and complete lack of a cumulative hangover effect, it's absolutely perfect for day case surgeries. Plus, it causes way less nausea and vomiting than traditional inhalation gases.
Section 4. Thiopental and etomidate.
Now, what's really interesting here is exactly why propofol largely replaced the older drug thiopental. While thiopental also has a fast onset, it is highly lipid-soluble and accumulates gradually in body fat. Unlike propofol's clean first-order kinetics, thiopental can saturate metabolic pathways, leading to zero-order kinetics and a prolonged, groggy hangover effect for the patient. Plus, thiopental has very little analgesic effect. Propofol's rapid recovery simply made it the superior clinical choice.
Okay, I want you to mentally take a screenshot of this slide right now. If you replicate this exact table structure from our source text in your exam, your examiner is going to be thrilled. It summarizes the landscape perfectly. Propofol gives you fast onset and very fast recovery, but you've got to watch out for cardiovascular depression. Thiopental gives fast onset but a slow recovery due to that accumulation hangover. And etomidate? It gives you fast onset and fast recovery, but its main unwanted effect is significant postoperative nausea and vomiting. It is just a flawless comparative summary.
Section 5. Risks and Unwanted Effects. We have to be clear here. All intravenous anesthetics carry severe, life-threatening risks if they aren't managed by an expert. The key risks you absolutely must list are cardiovascular depression. Specifically, they cause myocardial depression and vasodilation, leading to hypotension, or low blood pressure, and bradycardia. Furthermore, they cause profound respiratory depression. Most critically, at supraanesthetic doses, all of these agents can cause death by total loss of cardiovascular reflexes and respiratory paralysis. The line between a perfectly timed surgical sleep and a fatal overdose is razor thin. Which leaves us with this final, truly provocative thought to wrap up your essay. How do we harness this miracle of a lightning-fast, 20-second induction while keeping the patient safe from profound cardiovascular and respiratory depression? Well, the answer lies in modern balanced anesthesia. That's where we use an IV agent like propofol just to quickly knock the patient out and then seamlessly transition to an inhalation gas to safely maintain them, combining it with other drugs like opioids for pain. It is a beautiful, delicate physiological symphony. Take these structured points, build your paragraphs exactly as we've walked through them today, and you are going to absolutely crush your exam. Thank you so much for learning with me on the Explainer, and good luck with your studies.